the presenting author, Dr. Akshay Balaji, to talk on evaluation of the vision and quality of vision using extended macular IOL in ARMD cases with cataract.
Good morning, everyone.
Okay.
I'm Dr. Akshay Balaji, here to present on comparative evaluation of visual acuity, quality of vision, patient satisfaction after implantation of extended macular vision intraocular lens versus standard monofocal intraocular lens in cases of age-related macular degeneration with senile cataract. I have no financial interest. Age-related macular degeneration is a chronic degenerative disease of the retinal pigment epithelium and the choroid. It currently accounts to about 8.7% of the blindness in the world, which is roughly around 196 million in 2020, and is expected to increase to 288 million in 2040. As we all know, there are two forms of age-related macular degeneration. The neovascular form leads to accumulation of subretinal fluid and choroidal neovascular membrane, which can leave a macular scar in the advanced stages. The same way, non-neovascular form starts as drusen, coalesces to form a geographical atrophy, and leaves a macular scar. In both the cases, the macular scar causes central scotoma, which can be often disturbing to these patients. When these patients develop senile cataract, the outcomes of cataract extraction in these cases depends on the disease activity, the size of the CNVM scar, and the geographical atrophy, which often causes central scotoma. These are actually managed using low vision aids, which can be external or internal. And the disadvantages of external devices are reduced field of vision. It requires a lot of motivation from the patient side and are cumbersome to use. Whereas the internal ones are either Galilean or Cassegrain telescope model, but they are complex designs which requires large incisions and leads to a lot of perioperative complications. Keeping this in mind, we aim to study the outcomes of extended macular vision intraocular lens, comparing it with standard monofocal lens like IQ. So ours was a prospective interventional study done in Dr. Rajendra Prasad Center for Ophthalmic Sciences, and we included a sample size of 20 eyes divided into two groups. One group, 10 eyes were implanted with extended macular vision intraocular lens, versus the other group was implanted with standard monofocal IQ intraocular lens. We aim to measure and compare the visual acuity, quality of vision, and patient satisfaction post extended macular vision intraocular lens, and compared it with standard monofocal lenses. And also we studied the effect of central scotoma using Goldman perimetry, and assessed the safety profile of this particular lens. So we included intermediate dry age-related macular degenerative patients with senile cataract, stable neovascular AMD with central macular scar of less than 1 disc diopter, or a paracentral scar that spares the central macular area of at least 10 degree. And we included patients having Snellen's visual acuity of at least 660, and those who were willing to give voluntary informed consent to be a part of the study. We excluded unstable cases, those who required anti-VEGF injections, who had uncontrolled diabetic maculopathy, any other ocular and systemic comorbidities. So the results were, the baseline parameters were matched, comparable in both, and in visual acuity, the mean uncorrected and the best corrected distant as well as near visual acuity was comparable between the two groups. And we assess the quality of vision. We assess the mean higher order, total and internal higher order aberration at 3rd month follow-up, which was lesser in this IQ group compared to the extended macular vision intraocular lens, which was statistically significant with a p-value of 0.015. And also we compared the mean total and internal point spread function, which was comparable in both the groups. And the same with the MTF, but it was comparatively better in extended macular vision IOL group, but it was statistically insignificant. Patient satisfaction, we assessed National Eye Institute Visual Function Questionnaire, which had 13 questions clubbed under various subscales like general health, general vision, ocular pain, near activity, distance activity.
Please conclude, please conclude.
So the responses were found to be comparable. The safety profile, the limitation of the study was it was a pilot study with limited sample size of 10 patients. Cost-benefit ratio needs to be evaluated, and the efficacy of this in varying sizes of central macular scar patients need to be evaluated. So we conclude that there is significant reduction in the area of scotoma post-implantation of extended macular intraocular lens when compared to standard group, and it is safe as standard monofocal intraocular lens in cases of AMD with cataract.
Thank you. Do you have any question?
What was the name of the extended macular IOL which was used?
IOL AMD from Care Group, ma'am.
From
Care Group.
Care Group.
AMD. The name itself is IOL AMD.
And
it's
what
mentioned
all?
in your protocol. It's it's mentioned in your methodology.
Yes.
Is it mentioned?
Yes.
And what all investigation you do to find out the function of the macula?
Sir, I did a Goldman perimetry and we did a microperimetry also, and the scar size was assessed using optos, and we included only patients who had a macular scar of less than 1 dis diopter. Larger scar patients who did not have a healthy macula, even in the more than 10 degree, we excluded them.
What do you mean by healthy?
So the delineation of the scar basically.
That will not tell you the function of the macula. The function of the macula will tell you if you do the ERG, the let's say multifocal ERG,
No,
the
sir, that was so.
pattern ERG.
Yes.
Okay, nice presentation,
Thank you.
Akshay. Good. Please call the next one.
Now we start with the next. To assess the visual outcomes in 4 different types of extended depth of focus intraocular lenses. The chief and presenting author will be Dr. Deshpande.
Thank you so much. So conventional multifocal IOLs give a specific foci, and only the sharp vision is around the limited zone around the foci, and also there are issues of dysphotopsia and loss of contrast. In contrast, EDOF technologies give an elongated focal point with an enhanced depth of focus, and this aims to reduce photopic phenomenon, glare and halos. So we have compared 4 different EDOF lenses: LuxSmart, Alcon VVT, Rayner EMV and Acryl ICERT, and the outcome measures were uncorrected distance and visual acuity, intermediate and near visual acuity, post-operative contrast and patient satisfaction in all these groups. So we use type 5 EDOF IOLs, which are the lenses characterized by variation in the geometry of their central optical area. So methods were data from cataract patients was collected between January 21 and August 23. Age range was 40 to 90 with both genders, and we excluded corneal abnormalities, retinal abnormalities, prior surgeries, severe dry eye, and pre-operative, the expected visual outcome of 6/9 or worse. So demographics, again, and gender and female ratio was well balanced. We included with patients undergoing only phaco or those with flax and others like those who were combined with other glaucoma surgeries. Most of the patients, 5.4% patients had glaucoma, and 3.2% patients had some form of diabetic retinopathy, including 1 or 2 patients of cystoid macular edema. Then spherical equivalent, you can see 1 month and 3 months. There was an excellent outcome in all 4 groups of intraocular lenses. Only cylindrical IOLs were present in Alcon, were available in Alcon VVT and Rayner EMV. That is why baseline you see higher cylinders in these 2 groups. But if you see 1 month and 3 months, there was excellent outcome even in patients who had preoperative cylindrical power. Refractive add, you can see average add given was around 1.5, but Acryl ICERT had a higher add in this group, and which continued into 3 months. Some of the patients who came back on 3rd month, although the number of patients who came on the 3rd month were little less, some of them demanded higher near add, and so it was corrected and given a higher add at the end of 3 months. Uncorrected distance visual acuity was excellent in all 4 groups. Uncorrected intermediate visual acuity was best in LuxSmart and Alcon VVT compared to Rayner EMV and Acryl ICERT, with almost 90% patients having excellent intermediate visual acuity in LuxSmart and Alcon VVT group. Uncorrected intermediate visual acuity at 3 months was again excellent. Near visual acuity was 60% in LuxSmart and 70%, which were both better than Rayner and Acryl. And again at 3 months it reflected similar trend. However, again our number of patients at 3rd month were little laser, and some of them demanded higher ads, so that is why there is a change in the little bar height at 1 month and 3 months. The defocus curves were like this for VVT, Rayner and Acryl ICERT. LuxSmart and VVT gave excellent defocus curves with almost 1.5 diopter of depth of focus. Contrast was excellent in all 4 groups. Patient satisfaction again was pretty good in all 4 groups, but best in LuxSmart, Acryl Rayner and Acryl Isert. So all groups did quite well. So there were no severe subjective disturbing symptoms in any of the groups, and overall satisfaction, most of the patients answered to be very high or high according to the Presque questionnaire that we used. Thank you.
That was a very nice study.
So did you use all the 4 IOLs you did comparative analysis?
Yes.
They all are refractive base?
Yeah, they are at type 5 of lenses.
No, VVT is refractive base, that I know.
They all have altered surface of the lens, and there are
What I am saying, are they diffractive base or refractive base? VVT is refractive.
Refractive, of course.
No, all LuxSmart and all lenses are not refractive base. That's what I'm asking. You
So
compared
the-
4 lenses.
I agree. See, if you Rayner EMV says they are doing aberration correction, but when you see the classification of lenses, now Minivel is type 1, which is pure aberration based lens. So when you see the category of of the EDOFs in which they fall, all of them fall in type 5, where there is some alteration on the lens surface done in the central zone in a different way. Like maybe they are not exactly same optical principle.
I think acryl cert is diffractive.
Yeah, but again, that's what.
know.
But it falls when the categorization of lenses is done, it falls in type 5. So I agree with you. There are diffractive elements, but when there was a classification, it's published, so that they have categorized in type 5. So all of these lenses.
Where is this classification?
Uh, mm, there is a meta-analysis done, and I have taken it through that. I can't really exactly remember the. So there is a meta-analysis published, and where they have categorized these lenses.
Right. Thank you. Thank you very
Thank
much.
The next speaker is Dr. Lionel Raj. Is he here, Dr. Lionel Raj? Anybody who is going to present on his behalf? Lionel Raj? He's not there. So 4th speaker is Dr. Tanmoy Vaidya. His topic is, can we improve the performance of extended depth of focus intraocular lenses?
Yes. A very good morning to all of you. I'm Dr. Tanmoy Vaidya from Narayan Netralaya. So my topic is, can we improve the performance of extended depth of focus IOLs? No financial disclosures. So near vision correction forms the holy grail of today's refractive cataract surgery, where every patient wants spectacle independence and optimal near vision correction. So these are the choices we have as a surgeon.
Doctor?
Trifocal IOLs do give very good outcomes
I
in
don't
these
know
patients,
that.
but the issue is the patient suitability and the issue of glares and halos. So EDOF IOLs is the next choice. These lenses work by creating a single elongated focal point to enhance the range of vision. They give very good distance vision, but the issue is suboptimal near vision. So how can we improve the performance? Monovision, micro-monovision strategies have been used in these patients with good results, but at the end of the day, we are compromising on the distance vision in one of the eyes of this patient. So can we correct them with myopic astigmatism? This is basically based on the Sturm's hypothesis, where 2 focal points are created and the focal interval is there, and as long as the retinal image is clear, the patient's depth of focus increases. Another option is by modulating the spherical aberration profile. Multiple studies again have been conducted with variable results, including one of our own. The issue is all of these studies have been tested on monofocal IOLs. So we at Narayan Netralaya aim to assess the improvement in near and intermediate visual acuity in these EDOF IOLs by inducing the spherical aberrations and myopic astigmatism. These EDOF IOLs are comparatively more forgiving due to their broader landing zone. The main goal of this study was to have minimal or no effect on distance vision. So we did a prospective observational studies where 80 eyes underwent uneventful phacoemulsification by a single surgeon. 40 of these eyes underwent VVT implantation, whereas 40 eyes underwent IHANS implantation. Now IHANS, is strictly speaking, is not an EDOF IOL but a monofocal plus IOL, but it does have EDOF characteristics. The first arm was to induce optimal spherical aberrations. The patient's refraction post-operatively was checked by an experienced optometrist, and the distance corrected visual acuity was considered as a baseline to test on the visual adaptive optics analyzer, aptly named WOW. So this is a machine which is based on the Hartmann-Schacht aberrometer, where it can also where you can view and modify both the visual profiles, including higher order aberrations. So here, the spherical aberration was modulated at steps of minus 0.01 microns, and the distance corrected visual acuity was retested for all these targets. The median optimal SA for both of these IOL groups was minus 0.05. So this optimal SA is basically the near and intermediate visual outcome without worsening the distance vision. So defocus curves were tested for each of these patients yet again. So as you can see, the intermediate and near vision improved marginally without really compromising on the distance vision in both the dominant and non-dominant eyes. So a similar experiment was carried out by optimizing the cylinder. The similar process was carried out on the WOW machine. Here the optimal cylinder was taken by inducing a convex cylinder in these patients and making the patient myopic astigmatism. So the optimal cylinder again is at which the near and intermediate visual acuity improves without compromising the distance vision. These were the median values for the same. So each patient's optimal cylinder value was taken and the defocus curves were retested. Now very interestingly, the near and intermediate visual acuity improved significantly, but the only problem was that the distance vision was compromised monoocularly. So we went ahead and repeated this experiment binocularly, and as expected, the patients tolerated it much better. So as a conclusion, inducing a negative spherical aberration led to a significant statistical improvement in both the groups in the near vision defocus curves. Most of these eyes actually accepted a minute spherical aberration correction of minus 0.05 microns. So this shows that the EDOF designs was already optimized significantly. So as shown, the cylindrical profile can be altered but is tolerated better binocularly. So as we know that the EDOF IOLs provide good distance, intermediate and functional near vision, and SA profile alteration and myopic astigmatism can be strategies which can be used to improve it. So this can go ahead further when we personalize the treatment for every patient, and instead of using a blanket spherical aberration or a cylindrical profile, we can customize these treatments and optimize the outcomes. Thank you very much.
Good, very nice. Dr. Aruna, can you do ahead?
So very innovative. So which machine? This machine is from which
So
company?
this machine is from Voptic as the company, and it's the visual adaptive optical and adaptive optics machine. So you can actually input the spherical corrections, cylindrical corrections. You can change the higher order aberration profile, where you can induce coma in a patient, where you can induce spherical aberrations and retest it.
You have induced the spherical aberration in
Yes,
one
yes,
experiment.
ma'am. Spherical aberration first, and then the cylinder.
Good presentation, Tanmay. Just want to know why you compared with the IHANS lens. Why not just the monofocal?
Ma'am, actually the monofocal lens, the study has already been done by us. With the monofocal lens, the negative spherical aberration profile and the cylinder profile is not really optimized by the companies. So compared to that, the IHANS has already got a negative SA aberration of minus 0.27. So where it has an EDOF characteristic, but it's not really characterized as an EDOF lens because there's a drop off in the near vision acuity. So it's a comparable.
Can you, maybe you could have had a third group with just the monofocal?
Yes, ma'am. So we are planning on comparing all the three groups, monofocal, EDOF and a trifocal IOL in the future.
Okay, thank you.
Thank you.
Yeah, is the presenting author Dr. Akash Jain here? Yeah. So his paper is on evaluating contact of IOL with PC with respect to haptic orientation and CTR implantation using IOCT. Over to you.
Good morning, everyone. My name is Dr. Akash Jain, and this is the topic of my presentation today. I have no financial interest. So, toric IOLs have changed the way we handle our pre-cataract astigmatism, but there's only one problem. They tend to rotate a bit. Maximum rotation that has been noted is during the first hour post-surgery. So with that kept in mind, we thought of a research question if we can reduce this early IOL rotation. So this is our intraoperative OCT scan showing the lens. The anterior posterior surface of the lens are the first two lines, and the bottom line is the posterior capsule. Our idea was that if we reduce this gap, if the contact between the lens and the capsule is better, That would in turn lead to a better IOL stability in the eye. So this is what we try to achieve from that. Okay, so our first experiment was to compare whether orienting the haptic of the IOL in a horizontal or a vertical orientation would improve this contact. So with that aim, we proceeded with a study, conducting this study in a sample size of 100. We chose non-complicated cataracts with axial length white to white in normal range, and these were patients opting for a toric IOL. After a preoperative evaluation during surgery, the lens was first oriented horizontally, meaning the haptic was oriented horizontally. A intraop OCT image was taken. After that, in the same eye, at the same IOP, the lens was rotated vertically, and an intraop image was captured again for comparison. So this is a surgical video where I'm showing that after the lens insertion, now the lens is oriented horizontally. The scan to your right is the intraoperative OCT image, and we took a screenshot of the same. Now we proceeded with rotating the lens vertically. And the second image was captured for comparison. So if you compare these two scans, you would notice that I want you to take a look at the scan. The vertical, when the haptics are oriented vertically, the contact is much better as compared to a horizontal orientation of the lens. So that's exactly what we found in our results, where a difference of 20 pixel density is the difference what we had. So that's how we analyzed these two scan images in terms of pixel density. So we had a 20 pixel density improvement with a vertical orientation as compared to a horizontal orientation. We proceeded to the experiment 2, where a CTR, a capsular tension ring, was implanted in these eyes. Sample size was 100. There was a random selection of the CTR size. Again, non-complicated cataract patients with normal biometry values. After preoperative evaluation, we implanted the lens first. We took a scan. We proceeded with a CTR implantation, and we took a scan again. So this is a video showing the same. The lens has been implanted first. After that, the CTR is being implanted here. Yeah, so I just skip the CTR implantation part, and it is very important to ensure that the lens, the IOL, does not get entangled with the CTR. So that adjustment is being made, and then we took the second scan. So comparing these two scans, you would notice that after a CTR implantation, the contact is much better as compared to a pre-CTR implantation, as we see in this scan on when we compare the two. So what CTR does, it stretches the back to increase the contact between the posterior capsule and the IOL, and that's exactly what we found in our results, where CTR of a higher size, say 13, gave a higher contact. The difference was around 50 pixel density here as compared to 11, but there was an improvement with all three sizes. So this is the first study to study CTR and IOL orientation effect in the same eye. A real-time intraoperative OCT scan was done, and these surgeries were conducted at physiological IOP of 20 microns. I also want to draw your attention to that irrigation line. It's the irrigation cannula from eye, which is kept in the eye at IOP of 20 to ensure that the IOP is well maintained during surgery. So how does this study guide us further? So one, we should exercise more caution if we notice any sudden deepening of anterior chamber. While conducting this study, we noticed that sudden deepening these patients are more prone to IOL rotation in the post-op 1 hour period. Further toric IOL stability studies need to be done, but if there is a deepening of anterior chamber noticed in any cases, those patients should be excluded from the study, as they can skew your data. So companies can also design toric IOLs which can be positioned vertically for a better IOL contact, and in turn leading to a better rotational stability. And try using CTR in toric patients to prevent early rotation. What we noticed was vertical orientation was better as compared to the horizontal orientation, and CTR does improve IOL contact with the posterior capsule. Thank you.
Very innovative study, Dr. Akash. Could you tell me what the size of the CTR you used? 10,
So
12 or 11, 13?
Yeah, the size were 11, 12 and 13. And in this particular study, it was a random choice. But what we can also do in our practice is use the white to white as a consideration. What we routinely follow is that white to white of 10.5 would be eligible for a CTR size 11. Size of 11.5 would be eligible for up to 11.5 would be eligible for a CTR size of 12. Up to 12.5 would be eligible for a CTR size of 13.
You can do the same with an axial length also. Less than 24, 24
Yes.
to 28 and more than 28.
Exactly, correct. Yeah. So,
So
these
but
are the
if you-
parameters what we routinely follow during our practice.
Yeah, but you could have done a subgroup analysis also. What CTR size you used and what was the distance between the IOL and the capsule. That can also be analyzed.
What was
Yes.
the sample size?
100 in both arms, ma'am. 100 each, 100 eyes each.
Okay. So did you mention in the methodology that all the cases had a temporal clear corneal phaco?
Yes, ma'am. It was.
Yeah, because the
all-
orientation again, horizontal,
No,
vertical
I
will
completely
change.
understand. Yes, but all cases were. So this was a single surgeon single center study with a temporal topical phacoemulsification at physiological IOP of 20 maintained on the machine.
Quite a different study. Thank you.
Thank you.
Any difference in patients who were high myopes as well?
No, ma'am. We excluded high myopes. We wanted to conduct this study in patients with normal biometry. So we restricted ourselves to a normal axial length, a normal white to white, and a normal IOL power.
Very innovative, but I have a few questions. Number
sir.
one is, you know that if you keep the IOL in a vertical position, you get more of a negative photopsia. So that is one issue. And the other issue is you are measuring the distance between the posterior capsule and the posterior part of the lens. So at what step of the surgery did you do that? And what is the position or status of the irrigation fluid going on?
Correct.
And did you remove all the viscoelastic or not?
Yes. So the lens implantation was a hydro implantation of the lens. There was no viscoelastic use. Second, the irrigation cannula was kept inside continuously during the entire procedure. Third, after ensuring a perfect positioning of the lens, ensuring there's no tilt, the lens is well centered, is only when we opted for the screenshot of the IOCT image.
With
Even
the irrigation on?
With the irrigation on, yes, sir. So that was the whole point of the study, that we actually, in literature, there are many studies which do not consider IOP as one of their criteria. But if you want to compare lens orientation, especially with the posterior capsule, the IOP has to be a set factor. It can't be a confounding factor to the study. Is why irrigation was kept on at a constant irrigation of 20 so that it's more physiological. That was the whole idea of that study, sir.
Very nice. Very
Thank you, sir.
Next presenter is Akash Jain.
No,
Sorry, Hari Priyam. So एक से एक सब है. And our topic is Arvind pseudo exfoliation study. 10 years post-op results.
Good morning, thank you. So the purpose of our study was to be a prospective comparative study of the late postoperative complication rates in eyes undergoing phacoemulsification, both with and without pseudoexfoliation. This was a prospective multicentric study done at the 4 hospitals at Arvind Eye Care System. The PEX group included patients who had pseudoexfoliation and visually significant cataract, and the control group had patients with cataract without pseudoexfoliation. Subjects were then further randomized to receive the various IOLs and capsule tension ring. The inclusion criteria was patients who had visually significant cataract with pseudoexfoliation, willing for phacoemulsification, an endothelial cell count of more than 1,500 cells. We did not include patients with phacodonosis or pupil size equal or less than 3 millimeters. Follow-up was done 1 day, 1 month, 3 months, 1 year, and yearly thereafter for 10 years prospectively. We did not do the 9th year follow-up because of the COVID pandemic. The pseudoexfoliation group included 970 eyes of 970 patients. Patients were randomized to receive either a single piece or a 3-piece acrylic IOL, and each of these groups were further randomized to receive a CTR or not. The control group included 476 eyes, and patients were again randomized to receive a single or 3-piece acrylic IOL. None of these patients received a CTR. The primary outcome variables were IOL decentration and Nd:YAG capsulotomy rates, and secondary outcome was the visual outcome. The first year postoperative results, the surgical and first year postoperative results, the analysis showed that pseudoexfoliation eyes without clinically apparent preoperative zonulopathy were not at a higher risk of intraoperative or postoperative complications or worse visual acuity after cataract surgery. Again, at the 5th year follow-up paper, our conclusion was that the risk of IOL decentration and PCO were low in pseudoexfoliation eyes and comparable to those in control subjects. And also with uncomplicated pseudoexfoliation, neither the IOL choice nor the presence or absence of a CTR affected the outcome at 5 years. This slide shows the follow-up at each year. At the 10th year follow-up, about 21.6% of the patients had died, 65.5% followed up, and 13% were lost to follow-up. So excluding those patients who were died, about 83.2% of the patients completed their follow-up at the 10th year. The IOL decentration rates were 2.27% in the pseudoexfoliation group and 1.68% in the control group, and this difference was not statistically significant. Most of these decentrations were mild, except for one patient who required IOL repositioning and iris fixation. YAG capsulotomy rates were also similar at 5.5% and 5.67%. Looking at the risk factors for IOL decentration using the Cox proportional hazard model, the two risk factors we identified were capsular phimosis. The patients had a higher risk of decentration, and if the rexus did not overlap the optic edge during surgery, this was also a risk factor for IOL decentration. And risk factors for ND-YAG laser for PCO. Single-piece IOLs had a higher risk of PCO compared to the three-piece IOLs. Younger patients less than 60 years with probably more viable lens epithelial cells had higher risk for PCO. And again, if the rexus did not overlap the optic, these patients also had a higher risk for PCO. Looking at the logMAR visual acuity at the different follow-up visits, the pseudoexfoliation group had lesser vision than the control group at year 2, year 3, year 6, year 8, and year 10. Now, however, since this difference was statistically significant, but clinically this was not very significant. If you look at 0.12 versus 0.08 at the last 10th year follow-up, this both comes to about 6 by 7.5 visual acuity, so it is not a very different outcome in terms of the visual acuity. Comparing another study which looked at 10-year follow-up retrospective data, they had 0.22 in the non-PEX and 0.27. In our study, we had 0.08 and 0.12 as the final outcome. In conclusion, this is the first large-scale prospective comparative study with a long-term follow-up evaluating pseudoexfoliation eyes undergoing phacoemulsification. And in those eyes without phacodonosis and without small pupils, pseudoexfoliation did not confer a higher risk for decentration or PCO. Thereby, CTR is not required prophylactically in these eyes who do not have phacodonosis. And in these eyes, the choice of IOL did not matter, and the visual acuity was also comparable in both the groups. Thank you.
Very nice study, ma'am, and with a great sample size.
Hello, ma'am. I just want to ask a few questions. So, was IOP not considered in this?
Yes, we did.
Or
that is a different
glaucoma
paper.
did?
So we did have, when we started off, the pseudoexfoliation group's IOP was 14.3 and the control group was 14. Again, this was significant statistically, even to begin with, because the number was large, but again, not a big difference. So we also at each follow-up did, but this study we looked at only decentration.
In this paper, was phacodonosis and in
excluded.
They
so
were
we
excluded.
We did not include patients who had it either pre-op or during surgery. If we found any phacodonosis also or zonulopathy, we did not include those eyes.
Was the grade of that pseudoexfoliation noted?
So there was no actual grading. So we developed our own in-house way of saying, what is the grading. So there is no published literature which says this is how we can grade.
Any dislocation of IOLs?
Only one patient had a significant decentration but required iris fixation. All the rest
no dislocation as such in
no
the 10 years of
no. This one patient had pseudoexfoliation, so just the rate was extremely low. Just one patient over these 10 years follow-up had needed a refixation.
So have you put toric IOLs in pseudoexfoliation?
No, these were all straightforward monofocal. This group was all monofocal, but we do use toric IOLs in pseudoexfoliation if they've had no preoperative zonulopathy. We are not doing any study on that.
Madam, what I feel that at the end of the day, let's after 6 years or 5 years or 10 years, a long-term basis, there is some amount of phimosis, and these phimosis will little decenter your IOLs, and if you're doing torical, it'll give you a bad effect, and there'll
Yeah.
be little
So I think phimosis, I think most of it in pseudoexfoliation especially comes earlier on. So within after the first few months it may not come, but those eyes are definitely at a higher risk for further zonular loss and decentration. And the phimosis itself, as we know, toric IOLs, what is important is critical for the lens to stay in place is the first day, and the phimosis probably happens within the first month or two. So I think within this time, if it stays, you will not see a rotation of the lens per se, but we may see a decentration of the whole capsular bag complex, which I'm not here to say for sure because we don't know that data. We didn't do
we
that
have
study.
a study. We have a long-term study on the follow-up on such cases, and we found out that in uncomplicated in a long term, you get phimosis. You get phimosis. Whether it's what grade, probably it has to be done. A little bit of phimosis or more phimosis to the extent of the even the decentration and subluxation.
True.
So the decentration which you got, was it in the earlier phase, like less
No,
than?
it lasts the 10th year follow-up.
Oh, 10th year follow-up.
Yeah, we just had one patient. Thank you.
You have already published this study.
Not yet. No, we have only published the
5
first
years.
year and 5th year. This 10th year data is new, so we're just analyzing this. This is, the 5th year and 1st year we have published.
So now we move on to the next. Evaluation of three-dimensional heads-up display microscope for surgical learning by Dr. Verman.
Hi, morning everybody. So my topic today is evaluation of a 3D microscope display for surgical learning. So as we know, when we are doing phacoemulsification for novice surgeons, there is a steep learning curve involved. So for this study, we try to use a 3D microscope to see if surgeons will learn a little faster and safer. So achieving competence requires you to get fine motor skills, have good depth perception and spatial awareness. There have been attempts to use some techniques to shorten the learning curve. We use a 3D microscope. So how this works is, as we know, the 3D systems have two high-definition cameras that capture two different angles of view, which are processed by an image processor and transmitted to a high-resolution screen. So what we did was, in this method, we had 20 surgeons, all of them who had very less experience with cataract surgery. All had performed less than 10 surgeries. Each patient was given 20 cataract surgeries to perform, and all of them were well-dilated pupils and very standard grade of cataract. And all of the surgeons performed 10 surgeries on the 3D system and 10 on the regular traditional microscope system. And we all used a standard operating procedure. So every step of the surgery was very standardized. They all used the same instruments, same techniques, and same viscoelastic, same phacoemulsification machine, same parameters. So we knew that the procedure was fully standardized for all the surgeries. So this is the 3D system. We used the Zeiss RTO 800, and there was always a supervising surgeon involved. Whenever there's a complication or when the surgeon had any difficulty, the surgery was taken over. And this is with the traditional microscope system. We use the Zeiss Lumira system, where the surgeon was operating through the traditional binoculars and the supervising surgeon is seeing through the side scope. We use the ICO Oscar grading for phacoemulsification, which is a very standardized grading to grade every step of the phaco surgery. There are a total of 20 steps in this rubric. And there's a grade of between 2 to 5 that you have to grade the novice surgeon with. So there was one attending surgeon and a third supervisor who was seeing all the steps of the surgery and were given the appropriate grade for every step. So the rubric is very, very specific. So in case the certain step of the surgery had to be taken over, for that step, the novice surgeon in question gets a score of 0. So we followed this, so we had a total of 400 cases. Post-operative parameters were seen at the end of 1 month. BCVA was seen for all patients at the end of 1 month. The parameters that were checked were all the ICU Oscar steps. We used the Kolgomarov-Smirnov and Shapiro-Wilks test and Mann-Whitney-U for non-bad data. So we analyzed this. We also gave a questionnaire to all of the novice surgeons just to see what their subjective response was. This is the data. This is the cumulative score. As we see here, the minimum score you can get is 40. The maximum you can get is 100. Here is a difference in the bar and whisker plot between the 3D and the traditional microscope surgeries. As we see here, whenever they performed with the 3D microscope, the surgeons scored a lot better. This is the time taken. The surgeons, when they performed with the 3D microscope, took lesser time, whereas in the traditional microscope, they took more time. Overall, in terms of visual acuity, there was no difference. Complications-wise, there was no difference between the two, because the most common complication was PCR followed by DMD. But when comparison, when we are seeing the steps of the surgery, all the surgeons performed better on the 3D microscope, and individual steps such as capsule access completion, insertion of instruments into the eye, irrigation aspiration, and spatial awareness were all better on the 3D microscope. Here is the step-by-step breakdown. As we see here in the first 6 steps, capsule access completion was done much better on the 3D microscope. The other steps, when we start doing the phacoemulsification, like trenching, nucleus aspiration, rotation, all of this was done much better on the 3D system in comparison to the traditional microscope system. This is the final few steps, all of which again on the starred steps are the significantly better steps on the 3D system. This is the questionnaire response. All of the doctors unanimously responded that they felt very comfortable using the 3D system and felt no difficulty at all when transitioning from 3D to traditional microscope. So our inference is here that the 3D system gave a better quality of steps. The scores were higher, time taken was lesser, but in terms of visual acuity, there was no difference between the two. So in the discussion, we can say that the overall competence of the surgeons was better because they had better depth perception, better spatial awareness when using the 3D system. So this has already been used variously in vitreoretinal surgeries. So our study mirrored the findings in the previous papers where the 3D system was used for VR surgeries, where novice surgeons performed better. So I conclude to say the 3D heads-up system enhances stereopsis and ergonomics, makes it a valuable training tool for novice surgeons, and therefore can be used in the future as a standard of care when teaching novice surgeons phacoemulsification. Thank you for your attention.
Nice study. Which 3D heads-up display did you use?
The Zeiss Artivo.
Artivo.
Yeah.
Okay.
So Narayana Nethrali is very rich. You can have these kind of arrangements.
So I'm not from Narayana Nethrali.
I'm sorry. Okay. Anyway, so yeah. Point number one. The point is, it's a very, very costly affair.
True.
It's not a one-time purchase, but it's also, you have to go for an annual maintenance contract and CMC, etc. So it's very, very costly affair. And what I feel, I've used this for 3-4 months, and I didn't like it because, if you do the surgery for a longer time, you get a headache because you have to have some kind of a difference of image in both the eyes to get the stereopsis.
Correct.
And number 3 is there is always a little bit of gap real time. You get the image after fraction a few more seconds. So that's the problem. So what is your take on this?
Okay, sir, as in terms of the lag time, I'm not sure which machine that you are using, but in the Artivo, the lag is very imperceptible. Technically, there is a very minute lag, but practically when we use it, it is not there. In terms of the comfortability, ease of use, the funny thing is, experienced surgeons who have done 10,000s of surgeries, they find it more difficult to adapt to the system. Whereas in this study, we all use novice surgeons. We feel the neuroplasticity is better. So they're able to adapt faster to the 3D system in comparison to experienced surgeons who have been doing thousands of surgeries on the traditional microscope.
So this is not for the experienced surgeons.
It's not for the old surgeons.
No.
Fantastic.
Right.
So there's a learning curve to it? I mean, after how many cases did you take this data of the surgeons?
So no, eventually everybody learns, ma'am. So it depends.
What is that
but
number?
Yeah, what is the learning curve?
How many surgeons?
It's very variable, ma'am. So see, but as of now, all the surgeons at the center, experienced, novice, everyone is using the 3D
Have you
now.
used?
Sorry, ma'am.
Have you been using this?
Yeah. So now all my surgeries
What do you
are
think
on
are
3D.
the disadvantages of?
Only disadvantage is the
Downsides,
turnover time because it's a fixed monitor and one bed. You can't have 2 beds, so you can't do right left. So you have to do all rights and then all lefts. So the turnover time in terms of bringing the patient in and all of that
For
is
a high volume
high volumes
center.
little more. Yeah.
Okay, I have seen surgeons having this RTO and finally operating through the oculars.
Yes.
What is experience, if you continuously doing the surgery on 3D?
Yeah.
Continuous surgeries, let's for 1 hour, 2 or 3 hours.
Ergonomics is much better, so you're not hunching over, you're not looking into the binoculars, so you feel more relaxed and comfortable as
Good
you're
for
operating.
neck and the
Exactly,
backache? What about
exactly.
the headache?
Exactly.
So you have some ache.
Yeah, I have some ache. Thank you very
Right.
much.
Thank you, sir.
So our next.
That's okay. So our next speaker is going to be speaking on use of total keratometry in IOL power calculation. Is it a game changer? And the speaker is Colonel Madan Deshpande. Dr. Barucha.
Respected chairpersons, members of the audience, a very good morning and greetings from HV Desai Eye Hospital. My talk is on use of total keratometry in IOL power calculation. Is it really a game changer? Cataracts, as we know, is a leading cause of remediable blindness. Cataract surgery has evolved from what used to be just a vision restoration surgery to a more refined refractive surgery. Technology is now available to reach this goal. An accurate pre-operative measurement of optical biometry is the key for a precise post-operative outcome. Cornea, as we know, is the most powerful refractive element of the eye, contributing about 70% of the refractive power of 43 diopters. Anterior surface contributing about 48 diopters and posterior a -6. Keratometry started as early as in 1619 when a Jesuit priest called Christoph Schneider started studying the corneal curvature and tried to measure it. Over the years, it got better, and we developed a keratometer for clinical use. Standard keratometry relies purely on measurement of anterior corneal surface. Traditionally, keratometry is measured assuming a fixed corneal posterior to anterior ratio or a Gulstrand's ratio. And it's calculated using a standard keratometric index of 1.3375. The anterior curvature, the posterior curvature, and the corneal thickness, all three contribute to the total refractive power of the cornea. So ignoring the posterior corneal curvature may lead to inaccuracies and significant overcorrection or undercorrection. The IOL Master 700 is a swept source OCT based optical biometer which we used in this study. This machine first builds an anterior toric model with telecentric keratometry and then measures the pachymetry using a swept source OCT. The pachymetric values are then fitted onto the anterior toric surface model to create a posterior toric surface model. And then total keratometry is calculated using the anterior, the posterior corneal curvatures, and the corneal thickness. Pentacam and Sirius also use Scheimpflug imaging for measuring the posterior corneal curvature. In this study, we aim to compare the predictive accuracy of standard keratometry versus total keratometry in IOL power calculation, and we did the same for monofocal IOLs as well as toric IOLs. It was a prospective cross-sectional comparative study over 1 year. Patients over the age of 40 undergoing routine phacoemulsification with monofocals and toric IOLs were recruited. The availability of preoperative K and TK data from IOL Master was mandatory, and patients having more than 1.5 diopters of astigmatism were advised to go for toric IOLs. We had two groups, one for monofocal, one for toric. The IOL power for each patient was derived using both standard as well as total keratometry. Barrett Universal 2 and Barrett Universal TK calculator was used for monofocal as well, and Barrett Universal Toric and Barrett Toric TK was used for toric IOL calculation. Standard phacoemulsification with 2.8 millimeter incisions. Post-operative refraction at 1 month after surgery was measured by automated refraction, manual refraction, and confirmed subjectively. Absolute predictive error for K and TK was calculated. Absolute predictive error was the actual post-operative spherical equivalent minus the pre-operative predicted spherical equivalent. So we had 100 patients in both the groups, average age of 68, 40% females. We measured the average K for monofocal group as well as toric group, and we did not find much difference, statistical significant difference between the two. While for average astigmatism in the monofocal and toric group, we found a statistical significance between the two. Absolute predictive error in monofocal group, we did not find any significant error, p-value of just 0.2. While in the toric group, we found that absolute predictive error of total keratometry was significantly lesser than for monofocal IOLs. So just to sum up, in group A, the absolute predictive error between K and TK did not make much of a difference, which was monofocal IOLs, while in toric IOLs, it was significantly lower for total keratometry. Some other studies also have corroborated our findings. And so with the advent of new technologies, we can use TK, which is available in machines like IOL Master 700 for toric IOLs, but for monofocal IOLs, it did not seem to make much of a difference. Our references, thank you.
Yeah, your Wing Commander Khurshid.
Yes, sir.
Very nice study. But could you please tell me why did you not choose to go for a toric IOL if it's around 1.5 astigmatism?
We did
You
above
go beyond that.
Yes, sir. Yes.
Above 1.5 you go.
So
Usually
usually if it's with the rule, you take above 1.5, and if it's against the rule, then you take about 1 as the cutoff.
Okay.
So all your cases were with the rule?
Pardon?
Were all your cases, because you took standard as, in the methodology, as above plus 1.5?
The toric IOLs were above 1.5, yeah.
What was the sample size of the toric
100,
group?
100 each in monofocals as well as toric. Yeah.
Thank you.
Thank you.
Thank you, sir.
Our next speaker is Dr. Niranjana. She'll be talking about Argos. Argos versus IOL Master, a comparison.
Good morning, everybody. Dr. Niranjana is the chief author. I'm Dr. Shweta. I'll be the presenting author for our paper, which is Argos versus IOL Master 700, a comparison. So, as was mentioned previously, accurate measurements of ocular biometry are of prime importance in IOL power calculations. So, the measurements are usually axial length, keratometry, anterior chamber depth, corneal diameter, and lens thickness. So, as we all know, biometry can be ultrasonographic or optical. So under optical, in the subcategory of SSOCT based, we have IOL Master 700, which uses a single refractive index, and a relatively newer biometer, Argos, which uses a segmental refractive index. So the objective of our study was to determine the agreement between the measurements made by IOL Master 700 and Argos. There are no financial disclosures. So we conducted a hospital-based retrospective comparative study over a duration of 6 months, including 30 eyes. The inclusion criteria were patients who underwent biometry for cataract surgery with no prior ocular surgery, ocular trauma, or pre-existing ocular diseases. So in our demographic analysis, we found that majority of our patients were female, and the average age was 60.53 years. With respect to the axial length, we found that both machines gave good correlation between their readings, and the mean difference between the two was not significant, and the limits of agreement at 5% and 95% confidence intervals were found to be acceptable. We had similar findings with respect to the keratometry, where they correlated well when there was no significant difference between the two, and as well as the lens thickness. However, when we come to the anterior chamber depth, we found that they did correlate well, but the mean paired difference of 0.122 mm was statistically significant. And the limits of agreement at 5% were 0.07 and at 95% were 0.17. The white-to-white measurements, we found that they correlated well and there's no significant difference between the two. Coming to the IOL power, they did correlate well. However, there was a difference of 0.2 diopters, which was significant, but 0.2 diopters proved to be clinically insignificant. So this is just a summary of our results with the paired samples correlation, where we can see that all the values taken by the two did correlate well. And in the paired samples test, we can see that the anterior chamber depth is where we found a significant difference, and as well as in the IOL power calculation. So coming to our discussion, we found that in our study, the axial length correlated well. However, in a study by Yang CM et al., they found that in longer eyes, Argos gave a shorter reading, whereas in shorter eyes, Argos gave a slightly longer value. The K readings were similar in our study and in other studies that were done. With the white-to-white measurements, Yang CM did find a difference where Argos measured a significantly longer white-to-white. The lens thickness as well, Yang CM found that there was a significant difference, but however, it was not clinically significant. With respect to the ACD measurements, similar observations as ours, where Argos gave a longer value, was made by Omoto MK et al. And with respect to the IOL power that we obtained, it was similar in prior studies. So the limitations of our study is that we did not subcategorize based on axial length, so we did not come to a conclusion whether it was different for different axial lengths. And of course, our sample size was smaller, which also serves as a limitation. So the conclusion we come to is that the most of the measurements taken by the two machines were in agreement. Further research with respect to the post-operative refractive outcome needs to be done. The difference in the ACD measurement and its implication on IOL power needs to be analyzed. And there is definitely a need to study the impact of using these two machines in different axial lengths. Thank you.
Good, Dr. Niranjana. I find that there's a difference of Argos and the IL-700. You said that the overall length measured by Argos is little less than what you measured in the IL-700, and especially the ACD is very, very significantly high in Argos. So
Yes.
could you find out the reason why what is happening?
So one thing is Argos uses a segmental refractive index. So obviously in the anterior chamber, because it's measured through the aqueous, it uses a different refractive index versus what is used for the vitreous, whereas IOL Master 700 just uses one refractive index value to measure. So it
But
could
then
be because of
ultimately
that.
the result of
Yes, the
AL or
IOL
power
power-
calculation should have been the
yes.
same, but there is difference.
IOL power was not clinically significant, the difference in the IOL power. So ultimately, there may not be a clinical significance, but because our sample size is small, that serves as a as a disadvantage to come to any proper conclusion about.
So
that.
this serves more as a pilot study.
Yes,
sort of.
yes, ma'am.
Thank you.
I agree. I think your sample size is too small to really come to any conclusion. Until the time you don't have eyes which have like smaller eyes or longer
Yes,
eyes,
ma'am.
you will not be able to come to a conclusion.
Yes, ma'am. We are planning to do more in that aspect.
The refractive outcomes also
Yes,
has
ma'am,
one.
yes, definitely. Thank you.
Now we come to the last presentation of the session, comparative analysis of visual outcome of Indian enhanced monofocals and EDOF IOLs by Dr. Kuldeep.
Respected chairpersons, seniors, and my dear friends, I am standing in front of you to discuss the dilemmas that we face, especially with respect to the Indian IOLs, because very less literature is available as far as their performance and predictability goes. We all know that multifocal IOLs have their own disadvantages, and that's why the EDOF technology has come into existence. And there are various ways by which EDOF mechanism is exerted by IOLs to achieve the extended depth of focus. We are comparing two types of IOLs which have extended depth of focus by an apostrophe in focus, where the company claims that this can produce a central zone for near, larger mid-peripheral zone for intermediate, and outer zone for distance, and that is mainly by the peripheral asphericity to increase the effectiveness of near as a support for the optical power of the lens. And the second one is a Care Group's magnificent ultra high depth focus lens, which they claim that it enhances contrast sensitivity with true multifocality effect, thus reduces glares and halos, and that they claim it to be their patented technology. So both of them come in the similar price range, and we need to discuss the evidence which lens gives better distance, intermediate, and near vision. So that was the purpose of this study. It was a single center study where we included patients with less than 1 diopter astigmatism. A single eye was included, and a standard phacoemulsification where the incision was done on a steep axis was performed by an experienced surgeon. In all patients, optical biometry was performed, and we looked at uncorrected distance, uncorrected intermediate, and uncorrected near. You can see in this chart that both the groups were comparable in terms of demographic details, as well as ocular details, as well as grades of cataract. When we compare the distance visual acuity on day 1, day 7, and day 30, there was no statistical significant difference, but the important point to note is that almost 70% of the patients did not reach better than 6/12 vision acuity. So 30% had a vision less than 6/12, so that extended depth of focus, wherein that wide focus is achieved, not a central pinpoint focus, can reduce a distance vision a bit. As far as intermediate vision goes, in the day 1 and day 7, although the extended monovision or care group lens gave a better result, but at day 30, you can see that the better vision was good and borderline near vision and intermediate vision was there in Upper Swami group's extended depth of focus, because in 3 patients of care group's magnificent EDOF, it gave a poor vision. So it was not giving a consistent result. The same trend was observed for near vision, wherein although the good vision was achieved in EMV or extended monovision group, but overall, if you look, the predictability of good and borderline vision was better with the EDOF technology as compared to the extended depth of focus technology by care group. So we need to really look while convincing the patient for these premium IOLs and discuss their needs, look at their distance vision needs, and then counsel them for the individual choice of IOLs. So these lenses are available at an affordable cost, but when we are promising a result, we should be sure of the results. That's my point. Thank you very much.
Don't you think you should have done the study with both the eyes? I mean, like just one eye you done the study? So these technologies
we
are always...
We are doing it, ma'am, because right now the other eye is not operated in many patients before the abstract was submitted. So that's why I could analyze the eye, only result of the single eye.
So is there any Indian make EDOF other than the care group?
Icril is there.
Learning
That is actually that care group doesn't have a EDOF. That is the main.
Learning conioscopy.
They don't have a typical EDOF technology. They have a different technology. So if you look at how the EDOF is achieved, it could be aspheric aberrations, or it could be a contrast sensitivity, or it could be a spherical aberrations and pinhole effect. They have a different technology, so they don't call it as a EDOF lens. It is similar to IHANS technology, you can say.
So your results confined to between the care group and this.
Yes.
But IHANS is not EDOF.
That's what I'm saying, that Magnificent is also not EDOF. But they both claim that they have give a better intermediate, so we wanted to compare between that.
You said that for the intermediate distance, after a month's time, both are same, almost same.
Yeah.
So, what do you think is the cause? Is it the surgical procedure that is the cause, or incision site that is the cause, or is it just because of the lens? And it's safe.
When to achieve that extended depth of focus, the point focus is not there, and that's why there is a wide landing zone, and that can reduce distance vision to give a better intermediate and near vision. So that is the mechanism by which EDOF works. So in EDOF, many times if we look at single eye, the distance vision is not good.
Basically binocular.
Yeah, binocular vision we have to.
Sure, good.
Thank you.
Learn
We close the session, sir.
So I request all the speakers to come to the dais and let's have a picture with them.